Hello.
Hi, everybody.
Good evening.
Welcome
Good
to AI
evening.
Live.
I know. Welcome to AI Live.
We have some fun stuff tonight, don't we? We do.
We talk about anything and everything. You know, hopefully you guys get a little interactive today. I know it's a topic that everyone talks about and we play around with it. It's in the industry, so we decided to just chit chat about it and see what you guys thought about it and what we are seeing and go from there. And we can sidetrack onto any topic you guys want. So we're here to have some fun and really get this industry educated in the right way.
Yeah, we have a TV kind of up here. You guys can't see it, but when you guys type in questions, we can see your questions. So we want to hear from you tonight. We want to be interactive. We're going to bring up some things. We're going to ask you questions. We want to hear your viewpoints on what our topic is, like the Great Dissolve. Mm-hmm. Should we, shouldn't we, when, how much, all that stuff. We're gonna kind of banter back and forth tonight.
Yes, for sure.
Okay.
But first, we have some housekeeping. For those of you that know us, we have our Foundations course, which is our core course for any newbies, any beginners, or even if you're been in the industry for a little bit of time. It's a great course to elevate yourself. It's called our Foundations of Advanced Aesthetic course. There is one November 15th, and then our new one in the new year is January 24th. It's a lot of didactic that you have to go through. It is CME accredited, so you get your CUs and CMEs with regards to that. And then also, we bring you in, and you can come in and get hands-on trainings with us. So definitely reach out, look into our Foundation of Advanced Aesthetics. We start basics, but if you're at a different level and you want to inject other areas, we will guide you through that with our Foundations of Advanced Aesthetics course.
Yeah, we come to your level. So if you are already fairly advanced and knowledgeable when you come in, when you have your time to be with us, that 1 hour pretty much one-on-one, you tell us, you know what, I really want someone to be with me when I do the under eyes. I really want someone to be with me when I do the chin, really guide me through this process so you feel more comfortable at home. We're with you. So we're there to precept and mentor you in whatever area you want to do. If you're just learning to push jelly through a syringe, then we will help you do that too. But we go to any level in that course. That's why we termed it advanced with the aesthetics. So we really want to support you in whatever level you're at and be with you and mentor you. So that's good. Okay, the next one we have is Beyond Occlusions. So we have a live stream event coming up. And this is something that's going to be December 13th. It's going to be at 10 in the morning. And it is not just vascular events. This is assessing and treating complications that have to do with medical aesthetics. It can be anything from lasers to threads to microneedling to fillers, all different types of things that we're going to be looking at with medical aesthetics. What are the complications and what should we notice as a provider when we assess for any adverse events? And then how do we go about and treat them so that our patients have excellent outcomes? Yeah. So that's going to be a really, really good live stream for you guys to come and see.
So it's December 13th, as you can see. And then for you guys that are still on this biostimulator route, which we definitely love, I know the industry is about it, we are having our AI webinar on Renuva. So if you guys don't know anything about Renuva, want to learn to start injecting it, this is a great didactic. You can see the live demonstrations with regards to injecting Renuva. It's December 16th, 6 p.m. Pacific Standard Time, and we're gonna go over everything about Renuva, so you guys know if you guys want to get some more natural replacement for your patients that don't want fillers. This is essentially the building blocks or the honeycomb structure of the fat that recruits fat into the area, and actually will, you could say, last longer, because when fat's recruited, that stays for a lot longer than a filler can be into the area. So it is a great biostimulator, biorejuvenation type of treatment for your patients.
Yeah, it's an allograft matrix, so it's made from fat, but it doesn't have the DNA. So it helps you grow your own fat, which is pretty amazing. Pretty cool. I wish I invented that. It's pretty cool. We cool.
Could always use a little bit more.
I know, right? Can I have some right here?
And then, of course, don't forget our mentorship levels. If you guys haven't explored it, we have 3 different levels. Our basic level, and then our intermediate, which is called our, Insiders? And so that one is Majority of people join that one. It's a monthly charge. There's over 400 videos on them. It breaks it apart into either areas or anatomy assessment and how to inject it. They're nice bite-sized videos for you guys. That's the middle level, and then our founders level is the top tier. And you literally get access to a lot of different things, webinars for free, hands-on courses for a significant discount, and then we jump on a Zoom call with you guys once a month to kind of just guide, mentor you guys. Those of you guys that need some bantering back and forth, they're just bouncing ideas back and forth. That's what we're here for, because a lot of people work independently or feel that they're in practices where they don't get the support. That's where we come in, and we try to provide that support for you guys so that you guys can continue growing in the aesthetic industry properly.
Yeah, we want to be here to mentor you. We want to be here to support you. If you're in a clinic or a practice where you kind of feel like you're alone and you don't have someone to ask questions of and kind of bounce things off of, that's why we developed this mentorship program, so that you can become a member and you can watch hundreds of videos to kind of expand your knowledge. And if you have I have a patient tomorrow that I'm doing biostimulants on, let me go to that module where I can learn biostimulants and kind of refresh my mind with that. And then tonight on Tuesday, after this show, we have our mentorship call. So we have our Founders Club get on a Zoom call with us, and we're able to kind of talk back and forth and kind of look at answer questions they might have regarding their clinics or devices or treatments or outcomes, and really kind of be a mentor and support for those providers. And some of those providers are KOLs in the industry, some of the people who we have in our mentorship program. But it just goes to show you that we can never know it all, and we are always striving to learn. And that's why you guys are here, and we appreciate you being here for that.
All right, so I think that's it for our housekeeping.
Drum roll.
It's coming to the end of the year,
I know.
It is the holiday season.
Is that crazy?
Yeah. Halloween turned the corner.
It's Christmas time.
And it's Christmas time.
It's here.
All right. So as we end the year, I think this is a important topic. It is, the great dissolve. Should we dissolve? Should we not dissolve? What's going on? You hear this trend with regards to, filler this, filler that. It's migrating, it's moving, blah, blah, blah. I think there is a lot of different things that need to be addressed with regards to this. One is, yes, we do have a lot of patients that are overfilled. Sad thing. This is built up over years and years and years of fillers, and we can't tell patients it just lasts this amount of time because we really don't know how they break down completely. This is science, and when we look at the science and what the research has shown, if you guys really read the white papers, it's all subjective. Really, have you guys actually read the white papers yourselves? A lot of the filler research that got them approvals were based off of scales. So we injected them on the scale. They improved from here to here. They looks good. Let's follow them out a couple of months. Let's put a little touch up into the area, and then let's continue following them out. At 1 year out, look, it's dropped back down to a certain level. So we'll say that this has the FDA approval for 1 year, or the FDA approval for 18 months. So you guys have to realize these fillers don't necessarily completely disappear. What's to make us not question whether or not these validated studies are actually biopsied, ultrasounded? Do you actually see that the filler has disappeared? Or is it really that the person just aged another year, another 18 months, and some of what you built on top of their fat their own fat has started to disappear, especially in this GLP arena and stuff like that? Do these fillers actually, are they still there? Possibly. This is for you guys to continue to think about and continue to question about out there. But
yeah, I think that's so true. If you've been injecting for a while, or if you're even new to the industry or the specialty, I think that it's really important for us to understand that people's physiology is different. And what I really notice is that people break the hyaluronic acid fillers down, that we're talking about that right now, but people break that down at different rates. Some people break it down very rapidly. Some people break it down very slowly. We have seen in studies that Dr. Mobin Masters out of Europe has done, and he's seen filler that's been in the eye area, under eye area, for 12 years on MRI, when it's a hyaluronic acid filler that's approved for 1 year, 18 months. So it's stays there a lot longer. Some places last longer than others. I have seen it last for years in some patients, and others, they say, like their lips, sometimes every 6 months it goes away. I have a theory, and I hopefully I can get a study done on this, but I think that we probably have our own innate level of hyaluronidase, and that in and of itself is denoting the speed of breakdown of the hyaluronic acid. So I think we each break it down at different rates. And it very much depends on the molecular structure of the hyaluronic acid filler. Yeah. So they're not all the same. So you have to know rheology and how rheological principles are different. The cross-linking, the hyaluronic acid content, there's so many different variables involved in the rheology of filler that we need to understand that, because some of them we know are really, really hard to dissolve. And some of the companies aren't real forthcoming in the information about some of these fillers, so we don't know everything about them, but we know enough to know that it's like licking a jawbreaker when we try to dissolve it. So some of them break down differently. Some of them, and they're made to last longer, so that's why they're there for longer.
I mean, I definitely think that we have been in the industry, having been in the industry for, like, I guess 21 years now. You know, we have built layer upon layer upon layer upon layer, and I think there hasn't been this, this awareness now of what do we do now that we have built up layer by layer. It's kind of like painting over a wall. You keep putting layers and layers and layers and layers and layers of paint. Sooner or later, those layers of paint don't stick to the wall as much, and they start to peel off quicker. They start to fall off faster. And one of the things that I'm a big fan of when it comes to injecting is making sure you're precise about where you're injecting it. And I don't think in this industry people pay attention to where their needle point is, where the actual filler goes, because all of you guys assume I just go perpendicular and it should be where I injected. Well, if you think about it, especially with a shorter needle, I push, you're already putting pressure on a big fat cheek, so you're putting extra pressure downwards right in the area that you want it to grow, want it to lift, or want it to fill. What makes you think that your product isn't going squirt and going all over the place? And so now you have to actually overfill the patient just to get that fullness that you want. And then now when the patient starts to lose some of their fat, now you come in next year, and because the patient loved the results that you gave them, you go back in and squirt more, and you're building more, and then more, and then more year after year. And sooner or later, they end up with too much volume in the face because it wasn't done properly, because you guys keep chasing after the same thing. One of the big things that we kind of suck at as practitioners is really injecting the face in totality, because you get your patients who loved that first time. They loved the way you did their cheeks, looked beautiful, was amazing. So they're like, you know what, I'm going to save a budget and keep doing the same area because that cheek was so beautiful, and as I keep aging, that's what I'm going to focus on. Well, what about the temple that contributes to the cheek to continue dropping? What about the loss of bone structure and the internal rotation of the maxillary bone? What about the dragging of the tissue, the looseness of the skin that gives you this impression of things have dropped down? Have you guys actually tried to work on all those different layers and really work on the totality of the face rather than just focus on that one cheek and one cheek and one cheek because that patient tells you that they loved the results last year? And my analogy is kind of like you picked up an old broken house and you're remodeling it. Well, all the different rooms need remodeling, but we only have a budget for a certain amount. So you go and remodel the kitchen first. Well, if you remodel the kitchen first, by the time you come up with another budget, the patient goes, you know what? I remember I remodeled the kitchen and it made my kitchen so nice and we hang out there all the time. I'm going to put that budget back into the kitchen. And every year that budget goes right back into the kitchen and in the kitchen. Well, after a couple of years, what do you think happens? Your kitchen looks like Architectural Digest, and the rest of the house looks like shit. And you wonder why that happened. And all of you guys are probably, guilty of doing this for your patients, because you do that. You let the patients dictate what you do, because that cheek filler looks so beautiful. And you're going to keep doing the cheek filler year after year, the piriform filler, the lip filler, every year after year. And sometimes the lip filler isn't. It's a balance of a chin, balance of the ergotrin in the upper lip area, tightening up of the skin, doing some rejuvenation, remodeling of the tissue, the skin tissue, and the quality of that. If you guys don't work on all the different layers, you literally are that person that's that interior designer, like, just keep your budget on the kitchen. It'll overpower the rest of the house and it'll look fine. Those are the people that people call out because they end up with too big of a cheek or too big of a lip or too big of this, because you guys are not really doing them a service by talking to them and saying, that's enough over there. Yes, I know you loved it. It worked beautifully, but realize everything else is aging. If you're not talking to your patients about that, I tell them there's the 5 levels of tissue that are aging: bone, deep fat pad, muscle, superficial fat pad, and skin. If you don't address all 5 layers, what are you guys doing as a practitioner? It's kind of like the cardiologist. Well, this is probably medicine. It's like the cardiologist only working on the heart and not working on the totality of the body. I mean, this is the sad part in the state of medicine, is everything siloed out. We've done that in aesthetics as well. You just do a Botox and the Botox and the Botox. Great. But realization is, there's a lot of different other things that are going on in the face that will actually help the patient look more natural. It's when you do little things that help the patient look natural.
Yeah. We wouldn't be, you got good points. I love the points you brought up. We wouldn't have this conversation with you guys tonight if we didn't have people being overfilled. And we're talking about having the great dissolve, right? Everybody's getting dissolved nowadays. And the reason is because people start to look globally odd. They've lost their signature features. They've lost their subtle nuances of what they look like anatomically, because they've gotten so soft and so overfilled, they just look like one big bowling ball, or they look like Avatar. They look very abnormal. And you can pick these people out in a crowd. And when you can see fillers, when you can see work done on somebody, it's bad work. Okay? So it's really important that when we as providers treat our patients, we treat the why. We look, just what you were saying, understand where the bone ages, where we lose bone support, where we lose fat, what happens with the skin. Don't treat volume loss that's over on this table with something that has to do with skin sagging. So if I'm going to have volume loss, I can treat it with volumizers. If I have skin laxity, why treatment with volumizers, right? If I try to lift the skin doing this with this variable of aging, they're going to look like a bowling ball. They're going to look odd. And I think that's why we have a lot of people nowadays really looking at dissolving things, because we're seeing them globally just get all these fillers. The other thing is we've had fillers for 20 years now or more. Mm-hmm. So we've had these fillers. So these people have been getting fillers for 15, 20 years. Once in a while, some of them have come in, got it every year because they think it goes away every year. And it's been layer upon layer, okay? When we dissolve them, they look pretty thin. They look like, oh my God, it's awful. What's happening is we're dissolving the hyaluronic acid filler, but even some plastic surgeons you see on Instagram who are saying the hyaluronidase destroys tissue, okay? Even those that are saying this stuff, I want you guys to think about this critically. Hyaluronidase will only break down hyaluronic acid. It does nothing to the tissue. But if you have somebody who has had fillers for 10, 15 years and they're a little overfilled and you dissolve it, they're going to look thin. It's not destroying their tissue. What's happened is that the fillers have masked the underlying volume loss they've had over those years. And when you kind of dissolve the fillers, they come back down to where they normally would be 15 years later. And we've lost a lot of volume in our faces 15 years later. So understand that. We have to look at their underlying anatomy. Do we have to dissolve everything? No. I have people right now that I'm taking through a dissolving process. And like I tell them, I don't have to dissolve everything in your face. I just need to get you back down to where I can see your signature features and your special anatomical, subtle, personal nuances. And I can leave some filler in there. I don't have to take everything out, but I do need to get you back down to where you look natural. And these people that don't see it, I ask them to pull up a picture from when they were 20s and 30s. Find that picture and hold it up and look at themselves next to that picture. They will see that they don't look like themselves because they have that perceptual,
It's a perception drift. But
drift, like Sabrina talks about.
It's about the fact that a lot of practitioners focus on one specific area. They're like, I only inject here. They won't inject temples. They won't inject other areas. And I get it. Not everybody's that comfortable. But I mean, I think a glabella, a nose, I get it. Not injecting those areas. But I think a temple you can inject pretty safely. But that's the totality of the face. And I think when you start to focus on one specific area and you keep doing it and keep doing it, it is going to look overdone. Eventually, you look at celebrities that just keep focusing on those things, they end up eventually getting overdone. They had a time frame where they looked amazing and they looked good, but the problem is the control factor from you guys is realizing that there's more than meets the eye to just aging in that one specific area. It's global aging. And if you don't address the global aging by doing global things, what are you really doing? It's literally like my analogy. You're taking all your budget and putting into one room in the house where you were supposed to spread the love all over to make it a cohesive component of a living space. And so there is a necessity at some point to dissolve out those patients where maybe you don't dissolve it all, but you dissolve it so it softens out, and then you reposition by injecting other things. Because filler will reposition volume in the right place as long as it is related to volume loss that is really going to reposition. Like, I do temples all day long and I love it. And I do more deeper. I love intramuscular periosteal injection, and I think it just gives a nice little tuck up right into this area that does a beautiful job. Will it maybe disappear a little bit faster with some grinding and chewing of the temporalis muscle? Maybe, but it temporarily gives a lift that you can't get. I don't think you can get any other way. In my book, I think superficially you can try to get some. I'm still in an argument with that on myself of whether or not superficial works as well as deep on the aspect of it, but definitely the totality of it needs to be taken back into the control aspect of it. I think dissolving fillers is a necessity to start talking to patients about, not to dissolve it all. I think that is the extreme that you have, that people are like, oh, I don't want any fillers at all. Well, if you really think about it, out of the 5 levels, what is filler supposed to do? Filler is supposed to replace some of the bone loss and some of the deep fat pad loss. If you're not doing things like Renuva, if you're not doing things like fat transfer or anything like that to replace this fatty volume that really gives you the projection, then you're going to have to resort to doing filler to compensate for that. Biostimulators ain't going to give you volume, guys.
Yeah. Right.
I hear this all the time, like, oh, I'm going to put sculpture in the temples. Well, I ask them, well, where are you putting in the temples? Oh, I just injected it all down into the deeper portion because I wanted to be safer. I'm like, well, what does that really mean? You guys really need to think about what you guys are doing. Because ultimately, Sculptra, hyperdilute radius, any biostimulator needs to biostimulate, right? If you're biostimulator, what does that mean? You need a certain type of cell to stimulate. So if you're throwing things into the area, you need to throw it into the levels where these cells are going to be, not randomly just shooting product into there. Because I hear this all the time, and I'm like, okay, so you put Sculptra into there. Why are you throwing your fertilizer onto concrete? You want your fertilizer in the dirt, right? You need it to fertilize something. So to me, when you just randomly do things without thought and really, really understand, why are you throwing Sculptra into a temple? Like, if you're throwing it superficially, beautiful. That's where there are fibroblasts. If you're throwing in certain tissue planes where there are fibroblastic activity, great. You will increase the volume of the skin and some volume of the periosteum. That is not the same volume as fat.
Or fillers.
Or fillers.
Yeah. Yeah.
So you guys really need to put them in separate positions, understanding what volume is really about. Now, do I love biosimilars? I love biosimilars. I think it does a beautiful job for those that, especially in this preauricular area, that need that thickening up of this tissue and a little bit of that volumization from that skin quality, not the volume from volume of fat. That works beautiful. But you have to delineate what is what. And so sometimes I'm a big person that loves to inject the majority of my fillers onto the periosteum. I don't do too much on the surface. I really don't. If I were going to do anything on the surface, I'd rather use biostimulators.
Yeah.
Right?
Yeah, I think so. And when you think about it, the majority of our revolumizers should be supraperiosteal because we're losing bone and we're losing deep fat pads. That's what we're losing the majority of our volume with. So that's where we need to put the majority of our volumizers, both on the bone and replacing the deep fat pads. Our skin loses collagen and elastin, so that gets all lax and droopy. So that's where we need the biostimulators. Mm-hmm. Can we inject in superficial fat pads? Yeah, we can. But, use that as kind of a frosting. You want to bake that cake before you frost it, and you want a lot less frosting than you want cake. So make sure that cake is baked, and then you can kind of frost it with something that's going to kind of give you a little bit of contour or shape or help to kind of frost out little deficits like a nasal jugal groove. You can frost those out very lightly. So I think that's super important, is addressing the why first. Like, why do they have the flatness mid-cheek? Why did they lose that OG curve? Then we can put fillers. So I think if people understood the why, and we didn't have patients being injected wherever they complained of problems, they're injected, they complain of a marionette line, and the provider puts a bunch of filler in the chin. They're treating a symptom. They're not treating the cause. The cause is loss of volume out here and skin laxity. Yep. It's not loss of volume in the chin area. I'll almost guarantee you that. There might be a little bit, but not much. We get a little flatness, we get a width here. And so if you start putting a bunch of filler in the chin, you're going to get, on a female, you're going to get this thick, wide, masculine chin. And we see that all the time. We see it all the time. And I just look at it and go, God, the provider's treating the symptom. They're not looking at the cause. So somebody starts looking odd. It's like when we used to overfill the nasolabial folds years ago. We rarely do nasolabial folds now, but years ago we did that. We all learned on nasolabial folds, and people started looking like monkeys. They were flat. Baboons. They had no nasolabial fold. So those are areas that I commonly will kind of dissolve when they're overfilled commonly, because injectors are addressing the symptom and not getting to the cause. So that's why we're having to dissolve a lot of those areas, because they're being overtreated.
Yeah, people are chasing volume when it needs to be maybe repositioning of the fat pad. I mean, this is the reason why I'm a big fan of the threads. I know a lot of people talk bad about threads, but I will tell you, if you do threads correctly, it is beautiful. Majority of you guys that start doing threads, they take one class and think you're going to run with it after one class. You've got something up, smoking up your ass, because it took me 5 classes. Yeah. I will tell you, it's kind of like you jumping in from driving an automatic car and saying, oh, that stick shift, that looks easy to drive. I'm going to go ahead and drive that stick shift. And I'm like, yeah, it's going to take you a while to learn. And people don't want to spend the time, effort, money to actually learn properly into the field of the threads. And if you really understand it, the Russians, the Italians, the Europeans, the Asians for sure, they love it. I mean, the plastic surgeons are the one doing it. Plastic surgeons here are talking bad about it because, yeah, we charge $4,000 or $5,000 for doing threads. They're charging $50,000, $60,000, $100,000, $200,000 for a facelift. What do you think their motive is, unfortunately? Yeah. And granted, there are a lot of bad practitioners who do a lot of bad thread work. And there are also some bad threads. molded threads versus cut threads, a huge difference with regards to that. So, but the whole goal is it is there in that superficial fat plane, that superficial right underneath the skin, to grab onto that, reposition it up. And this is where I started changing the way I injected, because if I go like this and I lift you and just lightly, I'm not trying to pull really hard like this, but just like what you would do if you put yourself in a hair ponytail, right?
I call it a perk.
A little perk, right? If you go like this and you perk and you see this soften out, or you see this soften out with that aspect of it, you can guarantee if this looks smooth and it is not hollow, you're guaranteed that it's not a volume deficit loss. You should not go and chase after this area with volume, because it's not related to a volume loss. It's related to the lateral portion of the face starting to fall. Now, could you add volume back up in here and give a nice lift? Perfect. You could totally do that. Or you can take threads and reposition this nasolabial fat. You can reposition this lower malar fat that hangs down into the marionette. But you can see when you pull this out, if this goes away, it's not a volume deficit. Like, I don't need a volume deficit. I need a little bit of a perk. I need either some threads to pull me back up, or maybe some volume back here and volume back in here. But that is the understanding of not chasing after it and utilizing fillers to the end all game. And I think we do that. And the sad part is, when we teach on stage, or you hear your KOLs talking for any of the companies, we can only talk to you guys about injecting it into that dermal range, because that was how they got their FDA approval to utilize it. But in our own practices, do we do it that way?
Yeah.
That's why majority of the ones that are more for the superficial area, I personally don't use very much of. And I'm very honest with the reps. I'm like, I don't use this. I want fillers that are higher G prime. So I love my Radius. I love my Restylane Lift. I like my Defines. I like the contours, the forms of the world that are actually things I can inject deeper onto the periosteum to give me volume and reposition some of the structure of the face, because I want to replace that volume of the deeper fat pad in the bone structure that has gotten lost. I don't like to chase superficially. Maybe a little glossing here and there with a half a syringe or a syringe on each side, just globally, in the sense to just gloss it over, is fine to give immediate type of changes. But I like them with the hyperdilutes or the sculptures of the world, the biostimulators. And now with the newer research, we've already been doing this. You can mix with your sculptures, your hyperdilutes, with HA fillers, toxins. You can make your own concoctions and create a whole blend of a new version of biostimulator that has different effects, right? And so ultimately, there is a shift that needs to happen where we are dissolving some of our patients that look overdone. Now, do you need to dissolve it all? No, I think like what Lori says, you don't need to dissolve it all, but you need to dissolve it down to a certain point where you can say, you know what, if I add volume in here and this lifts this back up, this is going to actually look good because it's now not overly filled and not prominent. So I think it's prudent of you guys to talk about that with your patients. And, we hear a little bit about migration. I think that's the other thing you hear.
Yeah.
I mean, do you believe that these fillers are really migrating that much?
Yeah, we've seen fillers redistribute. We've seen it in the lips years ago. Not as much now, though. Now that we are injecting lips and very superficially, we're kind of avoiding the vermilion border and leaving that intact.
Or the muscle. We
injected
so, right?
We injected in
That's
and under
different.
that muscle. We were just sticking it everywhere. Now that we're very more aware of the layer of tissue, I have, in the last 8 years, I haven't seen one migration with the superficial technique. I haven't. But if somebody's migrated before, they're probably going to migrate again. Those little channels are already there.
Yeah.
But I think it had to do, I think Juvederm got the rap for it. They used to call it Moviderm. And I think that's wrong. I think Juvederm's a good product. I think that it had to do with the technique we used years ago. People used Juvederm because it's got a high hyaluronic acid content. It pulled all the water into itself and was fluffy, and you got big lips. Great. But I don't think that was the cause of migration. I think it was the technique we used that really destroyed the intact vermilion border and some of the tissue where it let. Your lips are like a pastry bag. It's like a J underneath there. And when you move and talk, it's like a pastry bag, and it's going to stuff it right back up.
What's your thoughts about filler on the bone?
I don't think I've never seen filler on the bone redistribute.
I would
haven't.
probably say majority of the filler, if it's in a position where you didn't want it to be when you're scanning it, it's probably because you injected it.
Yeah, I think so too.
I think it's because you actually you went perpendicular. And I always tell practitioners that train with me, if you think about it, if you have a hose with water and you go straight to the ground, can you control where the water goes? Really can't. So to me, I'm always a big fan of, if I'm using a needle, which I am more of a needle than a cannula, it's always at an angle. It's always at an angle, because at least I know if I'm putting the hose with the water direction in front of me, I know it's going to go at least in that direction, versus if I go straight down perpendicularly, where is it going to go? You don't have control of it. And I will tell you, majority of you guys don't realize that you're actually probably not putting all of what you thought right into the area. It's spreading because path of least resistance. And I'll tell you, you guys have examples of it when you've done crow's feet and you're injecting toxin and you literally place it superficially and you're like, oh, I want to create that little one bleb, and all of a sudden you see it creep over here and shoot over here, like, shit. I wanted to go there.
No.
Imagine that's what's happening with your filler, because you don't know path of least resistance of where your product is really going. So my recommendation, I always teach people, is to really take the other hand, and you are putting it where you should feel the filler moving or expanding the tissue, raising the tissue, so you can actually corral the product to where you want it to be. Sometimes you see me, I kind of pinch a little bit, so when I'm injecting, that needle where I'm at is actually holding it in place, at least in a controlled environment. I would probably tell you, majority of people don't even think of it that way, because everyone's just like randomly here injecting and their hand is somewhere else. And I'm like, okay, well, you don't really actually know where your filler is. And that's how patients actually do get overfilled, because now the filler goes out and spreads, and now it's in areas that you may not have wanted. It's more in neighborhood cities instead of actually where you want it to be, and you keep filling it.
Yeah, and I want to tell you, like Leona Schelke, who's probably one of the top ultrasound physicians in the world, runs a complications clinic out of Amsterdam with Dr. Velhes and Dr. DeCates, and they see a lot of complications. Every single nodule and complication she's seen as far as filler issues has been in the fascia, which means it's been placed in the wrong plane of tissue. If the filler is going to migrate or redistribute, it's going to be in the fascial layer. It's going to be in the interfascial plane, where if it's injected in the wrong plane of the temple, it can go right down to the buccal area. So we know that it can travel down fascial planes. It's a jelly, and the more it moves and gravity, it can travel, it can redistribute. So we want to make sure that we inject it into the correct plane of tissue. That we're either, I say, look at the face as a peanut butter and jelly, just a peanut butter sandwich. You got the bread, the peanut butter, the bread. Okay, bread, skin, peanut butter, muscles and fascia, smaz, and then the bottom layer, bread. Avoid the peanut butter. Don't go in the muscle, the smaz, the fascia. You would inject under the bread here and on the bread here. That's it. If you stay away from the middle area, you're going to stay away from the majority of the larger arteries, because the arteries are going to the muscle, the muscle's in the smaz. So if you understand what plane of tissue you're in, you're not going to have nodules unless you inject in a muscle. It's going to ball up, or on the fascia, and it won't redistribute. So you're not going to have any problem with migration. We don't have problems with migration if it's put in the right plane of tissue. So I think what that leads me to something with how do we dissolve? We're talking about the great dissolve. How do we do this? If you have somebody come in and it's somebody comes in and you say, okay, I want to dissolve you. I'll probably just do a few sessions. We don't know what's in there. You said sometimes you had Voluma, sometimes you had Lift, and sometimes you had some RHA, and different products are in there, and they dissolve at different rates. So how do you do that? Well, generally, you don't need to do full force hyaluronidase. You don't have to do it full strength. You can take. We have here in America, we've got the Hylenex. It's 150 units in 1 ml. And you can take that 1 ml and you could put a little quarter or half ml of lidocaine with it, and a little quarter or half ml of saline. So you can expand that to 2.5, even 3 mLs, that one vial. So you can water down your Hylenex. And it permeates the tissues very well. Hyaluronidase is used to permeate tissues for surgery all the time. So you can go in there with a cannula, and you can kind of go at different levels and just kind of almost like you're just spraying the area, like you're just frosting in the area, and kind of put it in evenly. And let the patient massage it for a while. It does all of its work within 20 minutes, and have them come back a week later or so. And you kind of look at them and go, okay, what does it look like? Let the patient know things can be a little uneven. I always warn my patients that. I haven't yet had a problem with it, but I always fear that one side's going to dissolve more than the other, or it's going to get a dent, but I've never had that happen. But bring them back a week or two later and reevaluate it, and you can always do another layer of dissolving. And you kind of water it down. It's not like you're having a vascular event. This is something that is something they want to do. We take our time, we assess where we need to put it, and we strategically place it in the layers. Like I can look with ultrasound and see where the filler is. So I have the ability to do that and kind of place it in the layer with my cannula, and I can strategically place it where that filler is. But if you don't have an ultrasound, you have to kind of take a guess and go, okay, superficial, mid, and deep, and just kind of spray it in, and you'll get a really nice result. But be conservative and just let the patient know it might take a few sessions. If it's something that's like a Vicross, like Voluma, Vibella, Volux, Velour, any of the skin, any of those, it's like we say, it's like licking a jawbreaker. They're very, very hard to dissolve. So those might take many sessions. And let the patient know, like if you've got any of those products in your face, it's just going to take more sessions to help lick that jawbreaker.
For sure.
Like you say. Yeah.
I think there was a question for temples. Do you recommend filler first or Sculptra and then Sculptra then? I mean, if you want to see immediate filling and lifting, I would definitely do the filler first and then Sculptra, because it takes time for that to grow. I mean, if you're working on skin quality, on the aspect of it, then you can start off with Sculptra and at any point in time come back in and do the filler. But
think I want you guys to think. I'm going to do a post on this, I swear. I want you guys to think about temporal anatomy. Like you alluded to the fact of, you have to know your anatomy. You've got the periosteum, then you've got the muscle that's glued to the bone on the temple. That temporalis muscle is glued to the bone. Then you got fat, then you got fascia, then you got fat, then you got skin. Okay, like there's 10 layers, but there's 5 in a nutshell. So if you're taking a needle and you're going straight down here and you're doing a depot of Sculptra or a filler, it is going in the temporalis muscle. You're doing an IM injection, and that's why it hurts for them to eat later on. It hurts for them to open and close their mouth, because you did an IM injection. Where is that deep temporal artery located? In the temporalis muscle, deep. So it's higher risk, and plus we don't want our fillers to go in the muscle. We want it to go supraperiosteal. So our goal isn't in the muscle. Sculptra, on the other hand, if you go down in the muscle, we don't really have fibroblasts in the muscle. If you go up a layer into the fat, is it going to stimulate fibroblasts in the fat? No. Fascia? No. Fat? No. Skin? We have fibroblasts in the skin. So that's where the Sculptra is going to be. The big bang is in the skin of the temple. If you go down deep and inject it in the muscle, you're not going to get much of a result with Sculptra. And we've done it for 15, 17 years. I've never been super happy with Sculptra in the temples, even though the medical tests, the FDA tests on HIV were done, with the lipoatrophy were done, and they had a nice result with lipoatrophy with immune compromised people. But I've never been super happy with it in the temple.
So inject it more superficially.
I'm not sure what layer in those. I'm not sure in those. If it was dermal, then I get it. Then
it was never approved
on
for
bone.
On bone.
Okay, that makes sense.
Recently on bone, it was all dermal. On their
so you can do a couple different layers on that.
For sure.
And somebody asked if there's a chance of a vascular issue. Yeah, there is with anything. Keep in mind that Sculptra, PLLA, is like a fog in water. It's such a small 20-40 micron product. It's so tiny that the risk of an occlusion is almost nothing. There's been one report of blindness, which I don't know. I
really understand it.
I just I question that. I don't know how that could happen unless somebody had a big thick glob of it and injected it into an artery. But it's such a small micron that it's going to be very difficult to do that. But again, don't go down in an area where there's arteries. Stay away from the muscles and the fascia and the SMAS. Just stay away from it.
But the vascular occlusion, I think, was related to injecting with a needle. I think all vascular occlusions are majority in my mind are probably because people are not really staying on the bone. They're going in straight perpendicular. Probably when they're aspirating, when you push, you actually bob up and down. We see it all the time. I really believe that it's that blood vessels typically are not going to be on the bone. It passes through the foramen. It passes over a notch. Those are the two areas that you're going to get blood vessel really close on the bone. You know, blood vessels may be on near the bone, and this is the reason why if it's very close to the bone and you're going at least at an angle, you may push that tissue, you may push the blood vessel out of the way. You know, even if you go through it, you're at more of an angle, and then if you move back and forth, you're going to be in the same tissue plane, versus if you're perpendicular through it and you're literally pushing and compressing that artery, you may be bouncing up and down into that blood vessel, and it could be right there. And so I think that there is a possibility in the aspect of it, you know. And we do notice, you know, when you are from anatomical dissection, when you go perpendicular, the path of least resistance can come back up the needle. People don't realize that just because you felt it down onto the bone does not mean that you're injecting it all down onto the bone.
Not can, but will come back up that needle.
Yes.
Yeah. It's always going to come back up the needle or cannula that you're injecting with.
And one of the other things that I see when people do perpendicular injections is if you see the tissue buckle, it's still like buckled down. When the needle's going in there, because maybe you have a duller needle, you're actually pulling the fascial tissue planes down. And when you actually inject, you may not be through all of the tissue planes and actually on periosteum. Right. So in those cases, you need to pick the tissue up and pull it and make sure that your needle has actually punctured through all of those fascial tissue planes. So these are the things you guys need to understand. It's not as simple as just injecting. I think people take it for granted. I know how to inject, and they just push things thinking that they are, but really not being precise and understanding where the tip of the needle is, where the tip of the cannula is, and really being precise about the placement of their product is really, really one of the important things.
There's a question about, I can't read tear trough. I've seen migration of filler in the tear trough. Have you seen this? If the filler's in the correct plane of tissue, it's not going to migrate.
Nope.
If it happens to be up higher in a superficial fat pad or above the muscle, it could probably move because that muscle's moving a lot. But if you've got it down on the bone, you've got the orbital retained ligament there that's going to kind of hold part of it. But I've never seen it migrate when it's placed in the right plane of tissue, which is usually on the bone. We don't want it above that.
Yeah, I mean, I think direction is going to be important when you're doing that. I always come at an angle. If you're going straight perpendicular, if it is traveling up the needle, who's to say that it can't travel into a more superficial plane as well when you're actually pushing product? You know, these are the things I think people don't think about as a possibility, even though you are injecting technically on the bone. If it is traveling up the needle, because that is a path of least resistance, you could put some here and it could still come up to the surface.
I'll tell you something that I learned in my lesson. With a needle in the piriform, I ultrasounded it. There weren't any deep arteries down on the bone, which frequently I see arteries down on the near the bone there. They're usually kind of in the LAO, actually, the vessels that come in from infraorbital. So I go to do a piriform injection. I'm injecting. I probably put 0.5. That's when I used to put more in there. And it looked great. The next day, the patient texts me and says, there's something up under my eye. And I said, what? She goes, yeah, there's something up under my eye. I said, come on in. The patient had filler right underneath the tear trough ligament. And what had happened with the filler that was a little bit, it was just put too much in here. The LSAN, moving the LSAN, kept hiking it up, and the filler ended up under the tear trough filler, like right in front of it. So it was interesting. Just dissolved it. It was fine. Nothing else migrated up, but it taught me don't put that much in the piriform, like a 0.3 at the most, and make sure I'm in the right plane of tissue. Make sure I'm down on that bone and not in any interfascial layers that could possibly hike back up. So I think that's why I probably used a cannula, but it was really interesting. Weird things happen. So, yeah.
I mean, that is the hard part, because we still are injecting blindly, and we don't really know where these products will truly end up. I mean, this is the reason why I'm a big fan of making sure, I call the hand that has your syringe and plunger, it's the blue collar hand, because all it is doing pushing fast, slow, and pulling the syringe in and out. The other hand is you could say white collar hand. That's the educated hand that should be telling you, giving you feedback of what's going on at the tip of the needle, what's going on there. Is the product going somewhere we don't want it to go? And you're corralling it and manipulating it so you're getting the product where you want it to be. It really is about being precise. I think people don't take that into consideration as much. It's like, oh, my needle's there, I'm shooting it there, I'm precise about it. And really Lori and I having watched like a lot of newbies, a lot of intermediates, you realize, that potential of actually being precise actually is not as precise as you think.
No.
People start to move their needle, you fall, you come off the bone. I don't know how many of you guys have started injecting things, and sooner or later you feel and you're like, ooh, I
not
came
on
off
the
the bone. I'm actually not on the bone.
Yeah.
And it comes down to it. When you start to push, you actually, the two phalanges, you actually pull up as you're pushing. You end up bobbing, and I'm sure somebody should do like an ultrasound study and watch people inject and watch that needle go up and down in the tissue. But this is the reason why, to me, perpendicular is a lot more precarious than going in an angle. If you go in an angle, I can slide onto the bone and slide further on and kind of
put that bevel right down onto the bone.
Onto the bone. And if I move back and forth, I'm still staying in the same tissue plane versus going perpendicular.
Yeah, and there are super periosteal arteries. You have arteries that are like kind of glued to the periosteum, but they're usually really tiny. They're tiny. Oh, yeah, you can't even you can't cannulate them. So those would not be really an issue. No. When you look at a cadaver course, they look like hairs. Yeah. They look like little hairs. Yeah. Let us know if you have more questions. This is kind of interesting. So dissolving, when somebody wants to dissolve and you're just kind of doing it gently and thoughtfully, you're going to water it down. If somebody has an adverse event, which is generally the majority of vascular adverse events are going to be vasospasm in nature. I've only had one that I know is an emboli. I know you had an emboli on you. But I know some are embolized, but like Leona Schelke, who treats these in Amsterdam all the time, she says that all of them are vasospasms. I mean, that's how confident she is, and everyone she's looked at has been a vasospasm. I've seen one where it's gone to the back of the eye. That was an emboli. You had one that went to your top of your head. So when you have something that is vascular in nature, no matter what it is, if you have a vascular compromise, you're going to inject that Hylenex pretty much full strength. You might throw a little bit of lidocaine in there for add some extra vasospasm or vasodilatation, but you're going to inject with your cannula, and you're just going to go in the different layers. If you think it's intra-arterial, then that's where you might want to cannulate a vessel and inject it in the vessel. But you'll go much more concentrated and full strength rather than watering it down. So I just want to differentiate that great dissolve component of it.
Yeah, I mean, I think you need to understand what you're trying to dissolve and how much you're trying to dissolve. If you want to dissolve a little bit, definitely really dissolve, either full strength, I still will add a little Lido, so maybe 50% of that 1 cc, add in a little bit Lido, that kind of dilutes it out just a little so I can get some spread. But I want to concentrate in the area. If you want to be a little bit more expansive and kind of more diffuse, you go to 1:1, which means adding a cc of a combination lidocaine saline. Or if you wanted to be even more dilute, you do a 3:1. That is going to be up to you and what you're trying to accomplish. This is the artistry. It's not about how much I'm going to do a protocol. It's really, do you want it very full strength to really dissolve it really strongly and really break down that product, or do you want to just softly take off the layer by layer by layer in the aspect of it? Then you can start to dilute it out. I don't think there's anything wrong with that.
We have a question. To reiterate the dissolving. So if it's something you want to do just slowly, I'll take a vial of Hylenex, which is 150 units. I'll mix a half a cc of saline, a half cc of lidocaine without epi. So that gives me 2 cc's total. If you want that one vial to spread even more, you can add a little bit more normal saline with it if you want. Yep. You don't have to add more lidocaine, but it stings. So if you add bacteriostatic saline with the Hylenex, it won't sting. Or if you add lidocaine, it actually helps to vasodilate and helps it penetrate more. So I'll just throw a little bit of lidocaine in there. So make it up to a total of like between 2.5 cc's in total per vial. And that's good to just, you're diluting it. It's not going to be full strength, so it's not going to dilute. It's not going to break down one spot of hyaluronic acid in one area. It's going to kind of soak it in a way and let it kind of penetrate. And I tell people this is kind of like pouring water in a bucket of sand. I don't know where that water's going to go. I can't denote the track of each little drop of water, so I'm not sure exactly how it's going to dissolve, but we look at it every couple weeks and assess it. Yeah.
Alicia asks, when dissolving filled lips, do you have any recommendations for refilling the lips that have friable lip tissue thereafter?
The dissolving the lips won't change lip tissue. You will break down their own hyaluronic acid. But if they had friable lip tissue before, they're going to have friable lip tissue after. So that usually has to do with the age. Usually older people have thinner lips.
I call it more Swiss cheesy. If it's more Swiss cheesy, like really floppy loose, then you want to actually use something soft first. So first to fill in all the holes, and then you come back in. And then you use more structural components. So you kind of need to create more support inside, kind of blow it up with softness and give it a little bit more of a generalized, just aerate.
Like bake their
Swiss cheese, and you want something cake soft that fills in those holes, and then you come in and give structure in that.
Yeah, if it's like an older lip and they've lost volume and they're kind of thin tissued, I might use either the Evolysse Smooth or Refine, Galderma Refine. I'll use one of those. Those are very soft, like egg whitey, and those give you that soft volume. And once you get that little bit of volume back, then you can use something that has a little bit more structure to it, like you can use Evolysse Form, you can use Contour, you can use Kiss, that will help give you a little bit more definition and shape to that lip if you need it, depending on what the patient wants. Yeah, good question. Thank you.
Cool. Good question. Any other questions?
Let us know if you have more questions, you guys. Thanks for asking questions. We love this.
Okay.
All right. Good deal. Good deal. Okay. So we kind of went through assessing, dissolving. Maybe the reason we have to dissolve nowadays is because it's been poorly placed filler. And unfortunately, we've seen a lot of stars that have poorly placed filler. So it's led to this whole fear of fillers.
It's also the fact that, we know these fillers can last a long time, and if you're layering upon layering and layering, when you're younger, and my analogy is when you're young, you're 18 years old, you get the nice poppy boobs that are up high and perky and stuff like that. You hit 40 and you're like, okay, I need to redo them. You may not get that perkiness. You may drop it down a little bit more tear-shaped and blah, blah, blah. So, as we change decade of life and you want that little bit more age-appropriate volume up repositioning, it may be necessary to dissolve out some of them and re-inject in the proper way that balances out to where their aesthetic is at that decade of life. So I think it is prudent talk to patients where you have to say, you know what, you've been doing these fillers all along, and maybe there is a little bit of this puffiness. Maybe you're pushing that, and they want a little bit of a change in the overall look of it. It is something to talk about. It's going to be something new that we have to think of in our industry. Is, these fillers are being laid upon layer and layer. Is there a proper way of just saying, at some point in time, let's knock down some of it and kind of rebuild it up properly?
Well, too, you need to remember that these, like we're saying, it lasts longer than we ever really realized before. We didn't realize years ago that these fillers lasted 5-10 years. So people were recommended to come in every year and get your fillers. So they did. And what we've really seen is that these fillers have been there for a long time, and people have aged. It's almost like a semi-permanent. People have aged and their structure has changed underneath. So the fillers don't fit their current supportive structure anymore. So sometimes we need to kind of soften the fillers that are there so we can kind of get back to their more natural look and to really kind of respect those structures that are there when they were 50 as opposed to 30. right? So it's the face changes every year, and the fillers don't necessarily change a lot every year. So we need to respect that and be really aware of that too. Yeah. Yeah.
All right.
Good stuff.
Well, if there are no more questions, I think we are at the last minute anyways. So let's see. What do we have?
Oh, we have our next AI Live is going to be December 2nd at 5 p.m. and it's going to be beyond occlusion. So that's what we are going to be talking about, navigating a lot of adverse events that are filler related, microneedling, all those different things that we need to assess, lasers, chemical peels, all of that. So we're going to be assessing and helping with treating those different complications.
And then in the new year, January 20th, if you are interested, we're already starting for 2026. There is going to be a webinar on cannula usage. I think this is important for you guys as a tool to be able to utilize cannulas. Everyone thinks cannulas easy to do, and we really disagree with that.
Yeah.
Cannulas really take a little bit of time, effort, and understanding on how to use it and how to use it precisely as a beautiful tool that can enhance your aesthetic results. So that's a great webinar for you guys to sign up for. That's going to be January 20th.
Yep.
And
this AI Live will be available on YouTube within a week or two, so you can always grab it on YouTube or tell any friends that missed it if you found some pearls that were interesting to you. We appreciate that. Thank you for tuning in, and we will see you December 2nd at 5 for our next AI Live.
Bye, guys.
Bye, guys.
Have a good night.
Thank you for watching, everybody. Remember to like and subscribe to our channel. And keep an eye out for all of our amazing videos. Are they gone? Can I stop smiling now? Because my cheeks really hurt.